Good afternoon, everyone. Welcome again to the 108 lunchtime snippet. Today, we're going to talk about total hip replacement. So I am Professor Prof Lee, and here's my qualification. I work in 108 Harley Street, and today we're going to focus more on hip replacement. So let's jump straight into it. What is a hip replacement? So we are basically changing the cartilage and the bone and replace it with metal and plastic and maybe ceramic, depends on the situation. It's a very successful operation and it's very routine. Now, in terms of hip replacement, sometimes patients do ask, do you just replace the bone? Do you replace the cartilage, or what else do you replace? So with hip replacement, we just replace the whole of the joint around the hip. So we take out the cartilage, we take out the bone, we take out all the surrounding tissue, but of course we're not cutting the nerves or any vessels nearby. This is what a hip arthritis look like. On the x-ray on your left, there is a hip that you can see that it's got arthritis in it, reduced joint space, subchondral sclerosis, and also you can see some cysts around there. This is a post-operative photos on a femoral head that we have just done a total hip replacement on. You can see that the bone at the top there is completely dead or arthritic, and this is the osteoarthritis process. This is just one of the photos that I have got. There are many different photos and show different way that the hip is worn. You can see that bone, sometimes people call it bone on bone arthritis, and that's what that means. Now, I'm sure I don't have to talk too much about why we need to do a hip replacement, how we're going to do it and things. But I want to just focus on a few things today about different approaches that is commonly used in total hip replacement. One of the more traditional approach is what we call a hard edge approach. Why do I want to talk about this? Because I believe that it makes a huge difference what approach that you use for the patient and how does it rehab. This is one of the patients that had a hard edge approach following hip replacement. You can see that she is limping. She got a very classic Trans-Danenberg gait and she is in pain. Of course, not everybody is going to be like that, and there is occasionally there will people be complaining of this sort of problem. And the reason for that is that the most important muscle around the hip joint is the gluteus medius. And for the lateral approach, the surgeon actually cut that muscle. Now, of course, we always say that we repair it, we put sutures through it, but sometimes depends on the suture, depends on the technique, depends on the patient's biology. This tendon may or may not heal. And if this tendon does not heal, patient would have a brand new joint, but they won't be able to use it properly. And hence, it is very important for us to try to protect that muscle. And the best way to protect it is not to repair with stitches, is not to cut it. So instead of a lateral approach, nowadays, many surgeons have converted to what we call the posterior approach. A posterior approach is cutting a different muscle, the short external rotator, which is these muscles here, instead of cutting the main gluteus muscle. There is pros and cons of this approach, but it has gained more popularity and patients tend to be recover a little bit quicker because the gluteus medius was not cut, was not touched. Therefore, patient is unlikely to develop a Trans-Danenberg gait. However, the posterior approach is known for increased chance for dislocation. Therefore, people will often say you need precaution after a total hip replacement. So this is just a schematic for me to show you in terms of anatomy about what structure and what detail that we usually go through in terms of the approach. As you can see, the hip joints is in the middle here. These are the tendons around there. So we can have different approaches, depends where we cut. And these 3 cuts here is all about a posterior approach. A traditional posterior approach, we take 1, 2, 3, 4, 5 tendon. Then we got a piriformis sparing. We save this big tendon here, save the piriformis. We just cut the 4 tendons down there. That is a posterior, the PS piriformis sparing posterior approach, and then later on I'm going to talk about the spare, saving all these tendons except just releasing this one little tendon there. Now, there are many different ways and different way the surgeon can do the surgery, and by saving these tendons, we will actually much reduce the chance for the hip to dislocate. So therefore, you will have the benefit of the posterior approach, but not have to worry about the posterior approach. We'll go through about that later. Of course, you might hear someone going to do a anterior approach or make a keyhole approach for the surgery. Now, my big question to you is, how big is your key? You can do a keyhole, but your keyhole just have to be very big. There is no way around it. The hip cup itself, the actual acetabulate cup itself, is approximately 5.5 centimeter in diameter. So the cut has to be at the very minimum 10 centimeters in order to fit in that cup. So you can have a very big key to have a keyhole. I think it is more of a marketing thing. So let's go back to spare. Spare is not a minimally invasive approach. It is not a keyhole approach. But what we do is we are protecting the tendon. We are saving the tendon. Remember the schematic that I showed you earlier on. This is the intraoperative picture. This is where the femur is, and this is the gluteus medius, which is the one that we definitely do not want to cut, which is give us all the power and all the force when we're walking postoperatively. And these are the short external rotator. So it's these one that we usually cut through with a posterior approach. However, on a spare approach, it's just this one. So we are releasing one tendon and then we put it back, attaching it. Another question is, can you actually do surgery without cutting any tendon? Of course we can. We can do anything. The problem is there is one thing that is fixed in a hip replacement, is the size of that implant. If the implants have the size of 10 centimeters, in order for us to stretch tendon, we have to really stretch them. You know what happened on a stretched tendon? They lose their elasticity. Like, for example, if you stretch a rubber band too hard, they will not become elastic anymore. It becomes plastic. And if that's the case, that tendon becomes non-functional. So actually, it is not a good idea to stretch all these tendons too hard. It's much better to release them and we reattach them back to the bone. And we have very good result with that. And it's actually much more logical. Now, in terms of the hip anatomy, this is just another slide of one of the study that we've done that to look at where these tendons attach to the back of the hip, and hence this is something that we use to develop the spare approach. Now, enough talked about the approach. We're going to talk about you may have heard of there are many different things that is available in hip replacement world. We talk about using a robot. We're talking about using a custom jig or custom implant even. There are cementing or uncemented implant. There is ceramic implant. There's also gold color implant. Each of them have their own function. Each of them have the benefit and actually have their problem. Now, two things I really want to talk about. One is about the robot. Now, it is a big hype in the moment. People talking about the robot and think that, yeah, it's really good. We can use a robot to put the hip cup in the right place in the right way. Yes, a robot can really help us to put things, but actually, if you don't know where is the correct location to put the hip cup and the hip stem and the way that it orientates in the three-dimensional space, a robot can help you to achieve where you want to put it, but it will not tell you where is the right place to put it. The right place to put it involves studying the patient, involve looking at the scans, looking at dynamic movement. A robot is just a tool to help you to put it after you have planned the surgery. And it's just only one way. There's other ways that we can use to plan the surgery. For example, custom jigs, which we use a lot, that is designed for the patient to help us internally to fit the hip replacement into the perfect location that we want it to be. There are different types of stems and there are different type of implant technology as well. So this slide here, I really want to show you all because this is what I think is the most important thing in hip replacement. Now, it is not a surprise that your hip is connected to your pelvis. Your pelvis is connected to your spine. Also, your knee is connected to your hip as well, through the femur. I know it is not a surprise, but actually we should not focus on the hip and the hip alone. This is why a lot of the time when we do hip replacement, I do x-rays for people that is sitting down, walking up the stairs, and when they're standing weight bearing. You can see here, these lines have shown what is the pelvis are doing. Is it tilting too much? Is it not tilting very much? And basically, based on that tilt, I then decide where to put that hip replacement cup in. And the hip replacement cup in the correct location will not have any dislocation. And this is a very, very important part of the planning process, and a robot do not help me on that. It is something that we do on the computer. We use digital planning, and this is not something that's done by the robot. And once that plan is made, we can actually very elegantly do it in surgery without the need of the robot. Now, in terms of surgery, it is not just about the approach. It is not just about the implant. It is not just about using what equipment. The more important thing is the whole of the journey. In 108 and in MSK Doctors, we believe that journey has to be tailored, had to be bespoke, and also patients do enjoy the boutiqueness of the surgery. We usually get the prehab, preoperative. We got a chauffeur to pick the patient up to the date of surgery. We perform the surgery as a day case procedure. Patient go home the next either this next morning if they want to stay overnight, or the same evening. Depends on the logistic, but patient can often go home the same day. Of course, that's down to the management of their pain and also education, surgical approach, and all those little things that we do and can help. And of course, if we manage that and we balance that right, we have very happy patient. And of course, post-operatively, we mustn't forget about our patient. We need to give them enough support, and we have a team of people that will help our patient. And this is a key slide for our total hip replacement today. So in terms of total hip replacement, we need to understand the anatomy and the mechanics. So we're replacing a ball and socket to a ball and socket. Hip replacement design, there are many. I can talk hours about it, but it is not something that we want to spend too much time on today. The key here is the spine. The hip is linked to your spine. Preparation will help a patient to achieve the best optimal outcome, and yes, it can be done as day case surgery, as we have been doing that for the last 3 years. Every single one of my private hip replacement is a day case surgery. Approach and technology, of course, we discussed about that and how it can help us to help the patient. Here is a picture of my very happy bionic joint cup patient, and they form a good support network for some of my newer patients. And if they want to speak to my patients about the newer journey, they are more than welcome to chat to any of my newer patients, and patients find it extremely useful. And this is the end of my talk about the total hip replacement. I hope that you enjoy the talk and you have a little refresher of what a hip replacement is and how important the spine is with the hip replacement. If you have any question, please post in the box, or please email it to Tina. But thank you very much for listening.